Hi, Dr. Bertram. It's me again, Tyler Parker from your MFT 6102 class for psychopathology diagnosis and treatment. So, for the week 6 assignment, I chose to watch the movie The Hours and do a clinical diagnosis and differential diagnosis for Virginia Woolf. Admittedly, this assignment was kind of difficult based on, I guess, the lack of information, clinical information from the movie about especially Virginia Woolf's past. So that was kind of difficult to try and fill in the gaps of, what I could derive from the information that was presented. I did read a bit about her biography, and I see that some places say that she had bipolar disorder. And so, at first I was kind of going along those lines just based on that, and kind of about her reports from when she lived in London about having, I guess you would call them manic episodes, or they could have been psychotic episodes. But anyways, I'll get into that differential diagnosis in a second. The primary diagnosis at first, I was leaning more towards major depressive disorder. But then when I went over the clinical criteria for it, I wasn't necessarily too convinced by it, especially based upon how long she'd had her depressive symptoms. So I think that persistent depressive disorder, or dysthymia, would probably be a little bit more clinically accurate and relevant. So just some brief overview about the clinical criteria. To depressed mood for most of the day, for more days than not, indicated by either subjective account or observation by others for at least 2 years. I definitely think that fit because of the reports of what others were saying by her husband and even by herself about the length of time that she's experienced her depression. Presence while depressed of 2 or more of the following. Poor appetite or overeating. I kind of thought that she might have had poor appetite just based on like her general attitude and mood, but of course that would need to be fleshed out in a clinical interview. Insomnia or hypersomnia, I couldn't really tell. I don't really remember. So I'd leave that one up in the air until I had a definite answer about it. Low energy or fatigue. Yeah, sometimes. She did seem to be pretty down, so you could say low energy. Low self-esteem, I didn't necessarily think that she had low self-esteem. I thought her self-esteem was pretty average, I guess. Well, besides the fact she wanted to kill herself. But, yeah, and I don't know. These other ones, the ones that I mostly was interested in was the poor appetite and the feelings of hopelessness. Of course, like you could try and categorize someone into any one of those clinical criteria, but the ones that really stuck out for me, the 2 of those would be poor appetite and feelings of hopelessness. Criterion C, during the 2-year period of the disturbance, the individual has never been without the symptoms. In criterion A or B for more than 2 months at a time. It seemed to be pretty persistent, and that's why I chose dysthymia rather than major depressive disorder. Criteria for major depressive disorder may be continuously present for 2 years. There has never been a manic episode or hypomanic episode, and criteria have never been met for cyclothemic disorder. Okay, this is where it gets this is where I had the difficulty. She seemed to meet the criteria for dysthymia, but she also seemed to meet the criteria for bipolar 1 disorder. So I'm not sure if they're mutually exclusive, because I know that bipolar disorder, on the unipolar negative or downside, you do have depressive symptoms. But I really, really, really think that dysthymia is a lot more prevalent in her case. But at the same time, like, you can have more depressive episodes than you have manic episodes. Like, if you at least have one manic episode, then you'd be considered bipolar. But mostly depressive. But I looked at the clinical criteria for the depressive side of bipolar. And, based on the length of time that she had where she was experiencing her depressive symptoms, I didn't think that she would really meet that better. I think that the dysthymia describes it a little bit better. when you sort of like tease out the differences between the two. So that's something that I would need to have, that question answered, because I'm kind of unclear about that one. Disturbance not better explained by persistent schizoaffective disorder, schizophrenia, delusional disorder, other specified or unspecified schizophrenia spectrum, or other psychotic disorder. Okay, so apparently she was hearing voices, right? But I have heard and read that sometimes voices that depressive people experience are more like thoughts and not necessarily voices. So, you'd really have to ask her if these voices were actual voices that were disembodied, or if they were thoughts of her own that she just couldn't get rid of. And that would sort of determine whether she was having psychotic symptoms or not. Symptoms not attributable to other physiological effects, substance abuse, medication, other medical conditions. Obviously, you'd have to rule that one out with a battery of physical tests. Her symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, yeah, and then with the specifiers, it's kind of leaning towards with mood incongruent psychotic features, just because of what, the reports were when she was in London. She had to be hospitalized. Onset, whether it's early or late onset, I don't really know. Yeah, and then I would also say with intermittent major depressive episodes, depending on when you were seeing her, it would be with current episode or not. And the severity obviously would be pretty severe because she's had suicide attempts already. So yeah, I think this one was kind of difficult in that case to sort of try and figure out exactly which one she was, because there are a lot of things that she meets for the major depressive disorder, but because it's so pervasive and it's happened for so long, over 2 years, then that would lead me more towards dysthymia. But at the same time, with bipolar 1 disorder, so for diagnosis of bipolar 1 disorder, it's necessary to meet the following criteria for manic episode. Okay, so she does meet, I think she met like the minimum number of criteria for this one. Distinct period of abnormally or persistently elevated, expansive, or irritable mood, abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present for most of the day, nearly every day. And especially because I don't know exactly how long those manic periods lasted at her previous residence. I wouldn't know whether that would be a manic episode or considered a hypomanic episode, because they both have similar or the same clinical criteria. During the period of the mood disturbance and increased energy activity, 3 or more of the following symptoms, or 4 if it's only irritable in her manic episode are present to a significant degree. Okay, so I'll just go over the ones that I thought were probably clinically relevant to her case. Decreased need for sleep. I think I remember she said something about that, but that's something that obviously you should need to ask. Okay, flight of ideas or subjective experience that thoughts are racing. I would kind of say so, because the way that she was describing how she felt so alive when she was there, and I can imagine that that's probably the sort of thing that she was experiencing. So I would say that she probably did have that. I wouldn't say really distractibility, increasing goal-directed activity. I heard that, or I read that she was involved in the intelligentsia of the day and in her area, so I could probably imagine that she would be involved in a lot of goal-related activities and social engagements and different writings that she would be involved in. Sharing of ideas and the such. So I think that she would probably fall into that one. I don't know about excessive involvement in activities of high potential for painful consequences, besides the fact that she was suicidal. I know that she was kind of out of control, so I guess it would be, I'd have to know for sure what kinds of activities that she was involved in, but I think she would also fall into that one. The mood disturbance is sufficiently severe to cause marked impairment in social occupational functioning or necessitate hospitalization to prevent harm to self or others. Yes, because she had gone to the hospital and now she's surrounded by doctors. The episode's not attributable to any other physiological effects. Don't really know, but that's, again, something that would have to be fleshed out during a clinical interview. So then you have the hypomanic episode, but like I said, this one's only lasting for 4 consecutive days. The episode is not severe enough to cause marked impairment in social occupational functioning or to necessitate hospitalization. If there are any psychotic features, the episode is by definition manic. So there was a hospitalization, and it did cause a lot of impairments in social functioning, so she would not meet the hypomanic criteria. And then, of course, you have major depressive disorder or major depressive episode. 5 or more of the following symptoms for a 2-week period. At least one of the symptoms, either depressed mood or loss of interest. So depressed mood definitely happens for most of the day. Markedly diminished interest or pleasure in all or almost all activities. She didn't really want to do anything. Though she was a writer and she was kind of moody, so, I don't know. You'd have to ask her how she feels about that. Significant weight loss. Don't know. Never got brought up. Insomnia. I'm really leaning towards that she did have sleep disturbances, but of course I'd have to ask her. I couldn't just go and say that that's something that she had. Fatigue or loss or energy nearly every day. She did look pretty sluggish. Worthlessness or excessive or inappropriate guilt. She wrote a suicide note that was kind of inappropriately guilty, I guess you would say. Diminished ability to think or concentrate. She didn't really say too much about that. Recurrent thoughts of death. Yeah, so that would definitely be the biggest signifier for her depressive episodes. Symptoms cause clinically significant distress. Yes, the episode is not attributed to physiological effects. Don't know. But yeah, and she's also not grieving. Okay, so what I had to rule out was brief psychotic disorder, and also probably schizophreniform disorder, just because she was talking about hearing voices and whatnot. So I went through the different clinical criteria and determined that she did not have brief psychotic disorder based on the ruling out criteria of that. She also didn't have like any other sort of schizophreniform or schizoaffective or anything like that sort of disorders going through the clinical criteria. So basically, dysthymia is a big one, and I want to put that one there with the specifiers that I mentioned, and also bipolar 1 disorder. Okay, so moving on. Discussion of the pharmacological treatment. All right, I've done a lot of thinking about this one lately, especially in real life, and it's really hard to figure out what parts of a person's dysfunction to sort of tackle first and to sort of work with first, because disorders, if they're comorbid with other disorders, are kind of like walled layers before you get to the core of what the person is. So if a person is depressive, but also they're bipolar, like they're dealing mostly with the depression, maybe like once or twice a year or whatever, they have a manic episode, then, dealing with the manic episode probably isn't the smartest thing to do, and probably won't get you the most healing out of the psychotherapy or the pharmacological treatment, because the depression is so prevalent. So I would definitely say, well, yeah, of course, bipolar disorder, you have to have pharmacological intervention to prevent the person from having a manic episode. And if they stop taking their medicine, then they're probably going to have a manic episode. So you'd want to tackle that. And also you'd want to tackle the depression too. But yeah, to get to the person, to talk to the person and to get them to understand or to work with their depression or the the disorder that is the most harmful to their daily functioning is probably going to take the priority. But if the how do I describe this? If the dysfunction is really, 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 really bad, but there's another disorder that's in front of that that's going to keep you from getting to work with that other one. Like, say, for example, random example, but if someone is hearing a lot of voices and they're really disheveled and they're, just crazy, 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 but you can't really talk to them because they're really, really depressed and they're denying all the feelings that they're having. So if they're denying all the feelings that they're having and they're having a lot of depressive symptoms, how do you then go and work with their schizophrenia or their schizoaffective or schizophreniform, whatever it is, without first working through that depression so that you could even get in touch with the person that's behind it? And I think that that's where psychopharmacological treatments are really good, because they can sort of tamp down what's going on neurologically and what's going on neurochemically, so that you're able to reach in with psychotherapeutic interventions. Because otherwise, just like in the other previous readings, especially for like ADHD and things like that, some people need to have that medication so that they can even focus on what the person is trying to tell them. Otherwise, they're not really reaching into them. Like they're talking to him, but all the words are just bouncing off because they're so hyped up or so depressed or so whatever inside without the medicine that, they can't really make any good changes for themselves. So yeah, I definitely would say that she would need to have something to do with her depression, but also to deal with her bipolar so that she doesn't get the way that she was before. So I definitely would say, at the time, of course, they didn't have SSRIs, but I would say I'd probably prescribe her an SSRI and probably an antipsychotic, but like a newer atypical antipsychotic, so that she doesn't have any more bipolar symptoms, positive symptoms at least. So, attack the positive and the negative symptoms with antipsychotics and with antidepressants, and then of course with psychotherapy as well. What I thought was really weird was that psychopharmacological treatment was discussed, but also biomedical treatment was discussed. And I've read that people who are in like severe depression where psychotherapy and drugs are not working for them sometimes go under electroshock therapy. That would be like that would be a last resort. So I wouldn't even really consider that an option until every other option has been exhausted. And at the same time too, I think that it'd probably be good if she was prescribed maybe like an exercise regimen or a walking regimen, or going out and getting in touch with nature regimen, because exercise is also really important and can help somebody get pulled out of depression, especially if she likes to walk around a lot anyways. Just find ways to integrate vigorous activity into her walking or her other daily activities that she really likes to do anyways. I think that that's probably, overlooked a lot as a biomedical intervention, but it's proved to be efficacious and it's very cost effective. So I don't see why it wouldn't be a part of her treatment regimen. So yeah, skipping from pharmacological to biomedical, I would definitely say that those should be thought about. Discussion of psychological treatment. So yeah, for the depression, I guess a CBT battery. I mean, I don't mean to sound so plain, but I think that a CBT battery would probably be the best thing for her to do, because I'm a little bit afraid that some of the other treatment approaches, like a narrative therapy treatment approach, might just reinforce how she's feeling anyways, because she is a storyteller, and the things, if you listen to them, that she's saying are not necessarily illogical. She's right on point with what she's thinking and how she's feeling, and If she were to listen to those feelings and thoughts, it would give her the right ammunition to behave that way, to be depressed, thinking about we're all going to die anyways sort of mentality. Yeah, we're all going to die anyways, but that doesn't mean that you need to behave that way. So I think that, like, basically just like a CBT battery of challenging her thoughts and her behaviors and sort of trying to change those slowly over time would be the best thing that could possibly be done for her. Because I'm just a little bit wary of acknowledging more of the negative feelings that she's having, and saying that, that's okay, because she's right. And if you tell her she's right, that might just make her feel worse. So, I would lean more towards like a behavioral intervention, because I think that she's pretty much got the symbolic and the narrative world locked down. And you might not want to give her that. So yeah, definitely behavioral interventions I think would be the best. All right, so family therapy based treatment. Her and her husband have a very he's got a very medically supportive attitude. He moved away to a suburb to try and get away from the city where he sees that her problems really arise. He's obviously spent lots of money to try and get her into a good position, done all those sorts of things for her. But I don't think that he really listens so much. At least when they're at the train station, he didn't really acknowledge her feelings. Because she's saying like, hey, I know what my feelings are more than you do and everyone else. So you guys need to listen to me. This is what I want. And she basically says, if I choose death, then that's my choice. So that's really hard. And once again, that's why I think that that a narrative therapy approach, she would pretty much just turn that sword against everybody. And, there's really no disagreeing with what she's saying, because she's like, yeah, you are, you are right. The world is kind of depressing, this, that. So at least I wouldn't be the kind of therapist that would want to delve into that with her, because I can see what she's saying. So for that, I think to treat the depression would be a lot of psychoeducation, but also a lot of, I guess you would say, like validating types of therapy between the two of them, because they both need to have their thoughts and their feelings validated. I was actually thinking that the most poignant or likely to be successful therapy for them would probably be the solution-focused therapy approach. Because it would pretty much jump straight to the conclusion of what they would like to see, rather than just, floating through the way that their relationship is organized and things like that. But to actually get them to a point, or to see the eventual outcome that they both want, and just to validate that as, their own personal choice. Especially, given that people have the tools for what they want to be inside themselves already, and they just have to establish that within one another, and to really be validated by one another for that. So I think that would probably be the best thing to do. So hopefully this is long enough. Didn't quite take as long as last time, but I really did have kind of a difficult time with this one. Especially with the ruling out diagnosis and trying to figure out, which diagnosis was the best one to give, and to give one or to give many, and what to treat first. So that's also why, when talking about the intervention strategies, say for the pharmacological treatment, I would definitely try to treat the depression first, because it is the most pervasive. And then, after that has gotten to sort of a workable level, then you can sort of try and treat the bipolar, or the more manic sides of the bipolar, to understand that. I don't really think that it would be a good idea to try and treat both at the same time, just because that's kind of too much to handle. I think one thing at a time. And like I said, with the walled sort of defenses of how disorders play into one another, and guard the person from someone's interventions, you want to break down the foremost wall first, which is the person wants to kill themselves every so often. So you want to just sort of like keep the person alive. So I think that'd be the most important. The manic episodes, they can come and go, but hopefully they don't kill themselves during one. They're just sort of get in the way, but that's a secondary line of defense, I think, for the person. So anyways, yeah, well, I hope that's sufficient. So yeah, have a nice day, sir.